Oh, another challenging case. I don't get easy cases around here, do I? Here's a very pretty younger woman who wants lower eyelid surgery. She doesn't really know what it is about her lower eyelids that contribute to her aging appearance. She's just over 40, but what really bothers her is the fact that there's something about it that looks like old and tired, right? And to the entry-level observer, you look at her and you think easy peasy, take some of that extra skin off, or even just put some Botox around there, soften things up, call it a day. That's not really the case. I mean, it's pretty clear that she has extra skin. I see it even more on her left side than her right side, especially when she smiles. At repose, at rest, you don't see it. But when you look a little bit more carefully and she is at rest, you can tell, and if you could draw a circle basically around the eye socket, or we call it the orbital rim, that hollowing appearance, that hollowness, is really, in my opinion, is much contributing to her aging appearance as the extra skin, which isn't that bad. So what do I recommend in this situation? Visible tear trough, dark circles around the eyes, and hollows around the eyes, a little bit like mine. Fat grafting. And where do you take fat from a skinny lady like this? Well, the knees are a great source, and I can talk to you guys in person about that if you are interested. This operation, combined with a little bit of skin excision underneath the eyelid, is going to be a winning combination. Just like I do a lift and fill facelift, a lift and fill lower blepharoplasty is going to be just the answer. So on the day of surgery, I really evaluate the patient. You can see here that the areas marked in blue are the areas in the cheek that I want to project forward. The temples need to be filled to avoid sort of a butternut squash appearance, where you have that hollowing that shows a sign of aging. And the nasolabial folds in green to try and just eliminate some of the shadows rather than trying to overcorrect and fill those folds. That's my style. The other thing I like to do is to mark out areas where I'm going to introduce the fat and inject them with numbing medication. The knees also get injected as though I'm doing liposuction, because I am. By liposuctioning the knees, just like in the Brazilian butt lift video, I can recycle that fat for use in the face. Even skinny patients have enough fat in their knees for facial augmentation. The eyes are protected with these scary looking corneal protecting shields, and the field is draped as though this were a proper OR, which it is. A specialized fat harvesting cannula is used, which is a little bit mean looking, but allows me to take out really high quality fat pretty quickly. And I take out only as much fat as I need to avoid any contour irregularities. And I take fat out of areas that you would like to have a little bit of fat correction anyway, like above the belly button or inside the knees. My nurse Mickey will then perform processing or emulsification of this fat using the Tulip Nano system, which is pretty awesome. And she emulsifies this fat to such small amounts that I can inject it through a small cannula. The fat is then transferred to 1 cc cannulas and syringes, so I have the ultimate control, as though I'm injecting injectable fillers. And this allows me to feather through multiple approaches, tiny amounts of fat per area. This is going to avoid any cyst formation, any palpable nodules, and ultimately improve the fat graft take. In my opinion, fat is better than purchasable injectable fillers because it's more forgiving, it's more natural, and it's permanent potentially. You are going to have to overcorrect initially to account for some loss of the fat graft as well as the swelling from just the trauma of surgery, but it is a very forgiving, natural, and rejuvenating filler. Once the fat grafting portion of the operation is complete, I then numb up the lower eyelids. My objective here is to maximize her pre-existing volume in her lower eyelids, and so I only want to take skin. In most patients I take skin and muscle, but in this patient she truly needs all the volume she can get, and so I'm going to painstakingly dissect this very thin skin off of the orbicularis muscle, which helps you close your eyes, and redrape that. Warning, this gets a little bit gory, and so I'm going to try and summarize it pretty quickly. But by dissecting all the way down to the tear trough, just the skin off of the orbicularis muscle, I can have the most area to redrape and minimize any chance of lower eyelid malposition. This is imperative. Once everything's been undermined and redraped, I take a very conservative amount of skin. I'm talking maybe 2 to 3 millimeters throughout the entire area because I don't want any lower eyelid malposition, number one. Number two, a little bit of skin excision here goes a long way. The eyelids are then sewn shut, and the amount of excised skin is compared as a second way of looking at things and ensuring symmetry. I then apply steri strips for compression around the knees where the fat was taken, and the patient is good to go home.